Cellular adaptations to stress or injury and cancer, pathophysiology and diagnostic correlation. So physiology is the study of the function of the body, so how everything works inside of the body, all of the functional organelles, the organs, everything, and all of its processes. Pathology is the study of disease. When we put these two together, pathophysiology is then the study of the processes involved in the disease progression. So the study of how the disease functions, what caused the disease, what homeostatic imbalance happened to relate the normal function to now the disease state. So normal cells have a fairly narrow range of function or steady state, which is called homeostasis. Excess physiologic or pathologic stress may force the cell into a new steady state, adaptation. But too much stress exceeds the cell's adaptive capacity, and then that leads to injury. And the cells are going to respond to that injury depending on what type of injury it is and whether the injury is reversible, permanent, or leads to cell death. So this is a picture that may look familiar to some of you. Internal or external stressors or injuries are imposed on the cell all the time. So some internal stressors could be a lack of a metabolite or some enzymes not functioning properly. External stressors could be a chemical was put on the cell, or the cell got exposed to UV radiation, or the cell got exposed to some type of toxin. Or injuries, get in a car accident, or even something as simple as getting a paper cut. So all the time our cells are adapting to different stressors that are internal, external, and including injuries. The cell has the ability to adapt to certain stressors. So the cellular adaptation that's going to happen is it can produce more or less metabolites. And metabolites, I do mention quite a bit in this lecture. Metabolites are anything that the cell would normally produce, metabolize, or use is as normal function. So it's going to give out these or excrete them from the cell. It's going to use them internally, or it's going to metabolize them. So it's going to be outside things coming into the cell that are going to be metabolized. Sometimes metabolites are specific to certain cells or certain regions of the body. So if we see an excess or decrease in a particular metabolite, we know that that's the part of the body that's injured. And that's kind of the basis for clinical chemistry. It's evaluating the blood for different types of metabolites or analytes to determine which part of the body has an issue. Other cellular adaptations would be reproduce more or less, alter membrane permeability to influence cell transport, increase or decrease growth, and we're going to be talking about that quite a bit in these next few slides, or turn on or off genes. Now, if those cellular adaptations don't work, then the cell's going to die. The stress or injury exceeds the cell's adaptive capacity and the cell dies. Sometimes the cell dies right away. So if the injury is really bad, if there's a severe internal or external stressor, the cell dies. So it doesn't get the opportunity to try to adapt, it just dies. So that is the alternative path there. So here's another diagram that you can kind of follow along with. So we have a normal cell that's in homeostasis, doing its normal function, happy, healthy, functioning properly. Now when a normal cell encounters stress, it has to adapt. If it can't adapt, it's going to be injured. An irreversible injury can lead to necrosis, so tissue death, or apoptosis, programmed cell death. So necrosis is when it turns like black and it dies and you see a wide variety of tissue death. Apoptosis would be programmed cell death. So the cell itself is given directions to basically self-destruct. It'll start shutting down its normal processes and eventually it will die. So if there's injurious stimulation, then obviously we go straight to cell injury. If it's severe, then we have the irreversible injury, which can lead to necrosis or apoptosis. Or if the cell injury isn't that severe, it may be mild or transient. Transient typically means passing through. So it's just a temporary injury that isn't sustained for a long time. That's reversible, and we can get that cell back to normal homeostasis. Atrophy. Atrophy is the decrease in size or function of an organ. This can be caused by a bunch of different things. One of them is reduced functional demand. So if there's a limb in a cast, that would be reduced functional demand because you can't really use the limb that much and it's in a cast. So that would reduce the demand on it, and it would reduce the amount you use it. So there will be a little bit of atrophy there. Inadequate supply of oxygen, also known as ischemia. So if you have a constriction of blood flow that prevents adequate oxygen delivery to a particular part of the body, that can cause atrophy. Insufficient nutrients, so starvation, can cause atrophy. Interruption of trophic signals. A pinched nerve is an example of something that can interrupt trophic signals. So my dad actually had this happen. He had a pinched nerve in his back, which decreased the nerve impulses that went down to his right leg. So when you look at him, his right leg was like half the size of his left leg, and that's due to atrophy of the right leg due to the pinched nerve. Persistent cell injury or chronic inflammation. So if we constantly have some type of inflammation, a lot of autoimmune diseases cause persistent cell injury, increased pressure, like bed rest, and chronic disease, such as cancer. So here are some sample questions that are similar to what you might see on the exam. So a 45-year-old woman is investigated for hypertension, which is high blood pressure, and is found to have enlargement of the left kidney. The right kidney is smaller than normal. Contrast studies reveal stenosis of the right renal artery. Stenosis is a narrowing of an opening. So when we're talking about stenosis of the right renal artery, we're talking about a decrease in blood flow to the right kidney. The size change in the right kidney is an example of which of the following adaptive changes. So that would be atrophy. When you decrease blood supply to an organ, that's going to decrease oxygen flow to the organ, and you're going to see some atrophy. Another one, a 28-year-old woman is pinned by falling debris during a hurricane. An X-ray film of the leg reveals a compound fracture of the right tibia. The leg is immobilized in a cast for 6 weeks. When the cast is removed, the patient notices that her right leg is weak and visibly smaller in circumference than the left leg. Which of the following terms best describes this change in the patient's leg muscle? Again, this is atrophy. So we have immobilized it, it wasn't used for a period of time, and that causes the atrophy. Hypertrophy. So hyper means a lot, and trophy is talking about, trophic, what I usually refer to as like cellular eating or growth, getting bigger. So hypertrophic cells are going to be enlarged cells. So enlarged cells resulting from an increase in size of constituent cells. So more mRNA. Hypertrophy of the heart and hypertension. So here you can see an example of hypertrophy. So this part of the heart over here is enlarged. Hypertrophy of skeletal muscles in bodybuilders. Often combined with hyperplasia unless the cells are terminally differentiated. So for example, muscle cells. So let me explain hypertrophy and hyperplasia. There are a few slides coming up about hyperplasia. But hypertrophy is when a cell increases in size. So a cell, typically this size, becomes now this size. Hyperplasia is when a cell that is this size divides, so now there's multiple cells. So when we have hyperplasia, that's an increase in the number of cells. When we have hypertrophy, it's an increase in the size of the cells. And sometimes those go hand in hand. When you see hyperplasia, you also see hypertrophy and vice versa. The only exception to this is when you have terminally differentiated cells. So a muscle cell is terminally differentiated. When someone lifts weights and their muscles get big and bulky, the inside protein filaments increase, which expands the cell membrane and makes the cell physically larger. If you think about adipocytes, fat cells, when someone eats excess calories and those calories are going to go to the liver to be processed and the fats are going to be deposited in the tissues, the fat cells, the adipocytes, are going to grow larger. And if a person starts to go on a diet and starts to lose weight, those cells are then going to shrink down. So they're going to grow larger or become hypertrophic if they increase the amount that they eat. However, they're not going to necessarily grow more cells because adipocytes, muscle cells, neurons, those are all terminally differentiated. You can't just make more of them unless you have particular types of stem cells, and that gets a little bit more complicated than the scope of this course. So when we talk about hypertrophy, especially when we're looking at heart muscle tissue, if a region of your heart muscle dies, it can't then be replaced by other heart muscle cells. Those cells are all the cells you're going to have in your lifetime. It's not like getting a cut on your skin where you can replace those skin cells by growing new ones. Heart muscle, terminally differentiated, you're not going to be able to create new heart muscle cells. So if the heart's going to grow larger, the cells are going to hypertrophy. They are going to expand in size without increasing the number of cells that are present. So hypertrophy of the heart is an adaptation to increased workload. Hypertrophy of the left ventricle is a complication of hypertension or high blood pressure, aortic stenosis or the narrowing of the artery, and endocarditis, which is inflammation of the surrounding of the heart. Hypertrophic heart cells increase in size because more myofilaments are inside of them, and they have efficient contraction when you have more myofilaments. The amount of DNA and RNA is increased as well. Smooth muscle cells in the wall of the bladder, when obstructed by hyperplastic prostate, increase in size and number. Physiologic hypertrophy of the uterine smooth muscle during pregnancy is usually accompanied by hyperplasia. So during pregnancy, when the uterus expands, the cells do get a little bit larger, but then you also have that increase in the number of cells. The removal of one kidney, compensatory hypertrophy and hyperplasia. So if one of the kidneys is removed, you will have the other kidney become larger, but there will also be more cells in that kidney. Hyperplasia, an increase in number of cells in a tissue or organ. Endometrial hyperplasia is caused by the action of estrogen. Benign prostatic hyperplasia is pretty common in elderly men. This doesn't mean that they have prostate cancer, it just means that there's an increase in the number of cells in the prostate, and that causes the prostate to enlarge. A callus on the heels. So if you walk around without shoes for a while, you're going to get a callus on your heels. So that is an example of hyperplasia. Hyperplastic polyps of the intestine. Erythroid bone marrow hyperplasia. So all of those are different types or different examples of hyperplasia, but hyperplasia in general is the increase in number of the cells in a tissue or organ. 52-year-old woman loses her right kidney following an automobile accident. A CT scan of the abdomen 2 years later shows marked enlargement of the left kidney. The renal enlargement is an example of which of the following adaptations. So when we're talking about kidney tissue that is not terminally differentiated, so the correct answer would be hypertrophy and hyperplasia. A 32-year-old woman with poorly controlled diabetes mellitus delivers a healthy boy at 38 weeks of gestation. As a result of maternal hyperglycemia during pregnancy, pancreatic islets in the neonate would be expected to show which of the following morphologic responses to injury. So this would be hyperplasia. Metaplasia. Metaplasia is the replacement of one mature cell type by another one. An induced change in the type of mucosal epithelium, example from ciliated columnar epithelium to squamous epithelium, brought about by various forms of chronic injury. So if you have chronic injury, eventually the cells would convert to squamous cells. And the squamous cells are a lot more tough and resilient, so they're not going to do their function properly. It's not a good thing to have those, but it is more protective. So in areas where there's constant irritation, that would be more protective. So it's a stable change to another cell type. Columnar cells of the bronchial mucosa, cigarette smoke, change into stratified epithelium. Metaplasia is reversible. Metaplasia may progress to dysplasia and thence to neoplasia. So once you start to get different types of cells present, it may start to progress to dysplasia, where you have the cells kind of infiltrating a bit more, and then they could become neoplastic or cancerous. A 60-year-old man with chronic cystitis complains of urinary frequency and pelvic discomfort. Digital rectal examination is unremarkable. Biopsy of the bladder mucosa reveals foci of glandular epithelium and chronic inflammatory cells. No cytologic signs of atypia or malignancy are observed. Which of the following terms best describes the morphological response to chronic injury in this patient? So they're going from normal mucosa to glandular epithelium and then chronic inflammatory cells. So because these different types of cells are forming and there's no cancer, it says no different types of cells, no atypia, they're just typical cells, and there's no cancer because there's no malignancy, this one would be metaplasia. A 5-year-old boy suffers blunt trauma to the leg in an automobile accident. 6 months later, bone trabeculae have formed within the striated skeletal muscle at the site of tissue injury. This pathologic condition is an example of which of the following morphological adaptations to injury? This would be metaplasia, because they don't talk anything about cancer. There's not all of a sudden cancer forming in the skeletal muscle. It's just the bone tissue has now formed within the striated skeletal muscle. That is an example of metaplasia. Dysplasia means disordered growth, most commonly seen in squamous epithelial cells following chronic injury. Morphologically, it is characterized by variations in size and shape of the cell. So you're not just going to have a new cell type formed like you would in metaplasia. These cells are going to be various shapes and sizes. You're going to look at it, and typically you would want to see a perfect arrangement of all nice similar types of cells, and it's going to convert into a mess, and it's going to infiltrate, and it's going to be looking like all different sizes and shapes. Disorderly arrangement within the epithelium and nuclear changes consisting of enlargement, irregular borders, and hyperchromasia of individual cell nuclei. So here you can see the nuclei become really dark, and they're elongated. Some of the cells are round, and they're all different sizes. Dysplasia is the only one of the above conditions that we talked about so far that is considered pre-malignant. Although dysplasia often arises in previously metaplastic epithelium and can progress to malignant squamous cell carcinoma unless it's treated. So this is a good review diagram for a visual on all the different states that were discussed so far. So you have a normal cell cluster, and this has 4 cells in here. So in atrophy, the 4 cells would just get smaller. In hypertrophy, the 4 cells would get larger. In hyperplasia, the 4 cells would turn into 16 cells, or a bunch of cells. In metaplasia, these 4 cells would convert to different types of new cells. In hypertrophy and hyperplasia, you'd have the 4 cells get larger but also increase in number. Once you get to metaplasia or hyperplasia, we can then progress to dysplasia. And dysplasia is an irregular and uncontrolled cellular division where cells are produced of different sizes and shapes. So what is the correlation to clinical chemistry? Atrophic cells may produce less of their typical metabolite, or they may release internal cell contents. So as the cell is getting smaller, some of the contents may come out, or they may stop producing as much metabolite as they used to. That's something that we can test for in the blood. So for example, muscle atrophy releases creatine kinase into the blood. So you'd have elevated CK levels in the blood if they're having muscular atrophy. CK can be indicative of like heart damage and other types of muscle damage. So to kind of rule out or get more information about the patient and not think that they are having a heart attack or some type of heart issue, we would then start to look at the muscles and be like, oh, the CK is likely due to their atrophy in their muscles. Hyperplastic and hypertrophic cells may produce more of their typical metabolite. So if they're larger and there's more of them, they may produce more of a particular substance. Metastatic cells may produce new metabolites. Dysplastic cells may produce abnormal, excessive, or less metabolite. So different types of disease states and the different types of cellular adaptations will have an impact on what they produce. And a lot of those we can pick up in blood work. So then we move on to neoplasia. Neo means new, plasia means growth. So this literally means new growth. It's the formation of new and abnormal growth. Metastatic cells will not produce normal quantities of their typical metabolite. So in most cases, they'll produce less. In some cases, they'll produce more. They may produce something entirely different. The comparison of benign and malignant tumors. So when we look at growth, benign tumors are slow and they're expansive. Malignant tumors grow fast and they're invasive. Metastases, benign, do not metastasize, so they do not spread to other regions of the body. Malignant does. The external surface of benign tumors is usually smooth, while malignant is usually irregular. Benign tumors are typically encapsulated. That capsule makes sure that all of those cells that are differentiating and dividing, those are all staying in one localized area, and they're not spreading to other parts of the body. Malignant tumors do not have a capsule. Benign, you typically don't see necrosis or cellular death, while malignant you do. Benign hemorrhage, you don't typically see bleeding of any type or any type of bruising around any area. Malignant tumors, yes, you do. The architecture of a benign tumor resembles normal tissue of origin, so it looks pretty similar to what tissue produced it. In malignant tumors, it does not resemble the normal tissue of origin, so the cell shape, size, everything, all the features about the cells are different. Cells are well differentiated in benign tumors, but poorly differentiated in malignant tumors. The cells are produced quickly and haphazardly, so they don't have the opportunity to perfect their size, shape, and differentiation once they're in the malignant form. The nuclei, so normal size and shape, and they're uniform in benign tumors. Malignant tumors, they're pleomorphic, so different sizes and shapes of nuclei. Benign tumors have few cells go through mitosis. Malignant, many, and they're irregular. So when you do a tissue cross-section, you're going to see many cells in mitosis, and they're going to look like irregular stages of mitosis when it's malignant. And this is just a gross appearance of some features of a benign versus a malignant tumor. So benign tumor, you're going to have it completely encapsulated, it's enclosed, it looks nice, the cells inside of it are going to be similar to the cells that produced it, the surface of the skin is intact. When we look at malignant, typically you do have ulceration of the skin, so there's some type of opening, wound, sore, bleeding, bruising that you see on the surface of the skin above it. And obviously that wouldn't be the case if it was like deep in the abdomen, so that wouldn't eventually come up to the surface of the skin. But then there's invasive growth, so you have little parts of it that tend to grow out deeper into the tissue. There's necrosis, so you can see some blackening where the cells have died. Hemorrhage, you're going to see some bleeding inside of it. Then you have the tumor itself invading blood vessels or lymphatic invasion. So lymph nodes, lymph vessels, that's going to go into the lymphatic system and then eventually dump into circulation. So the biology of the invasion and metastasis. So first you have the lysis of the basement membrane. Then you have migration through the extracellular matrix, penetration of vascular and lymphatic channels, survival in the vascular and lymphatic channels, and exit into a new site, and then survival and growth as metastasis. So they're going to be inside, or you have the primary tumor. They're going to invade the blood vessel, and then they're going to be transported, and they survive inside of that blood vessel. And once they get to a new location, they're going to leave the blood vessel and be able to form a new tumor in that new location. Local invasion. So malignant neoplasms grow by progressive infiltration, invasion, destruction, and penetration of the surrounding tissue because they do not develop capsules. This is why surgeons do wide excisions. So even though the tumor may be just this tiny little spot, they are going to excise a wide range of tissue around it as much as possible so that any cells or any parts of the tumor that had implanted locally will be removed with the tumor. The development of secondary implants discontinuous with the primary malignant neoplasm and possibly in remote tissues. So that's the true definition of metastasis. So you have secondary implants, so you had that primary tumor was in one location, and cells have removed themselves from that primary tumor and implanted themselves into a secondary location. And it may be pretty far away from the original cancerous growth. Malignant neoplasms invade and metastasize by definition. About 50% of all patients with newly diagnosed solid malignant neoplasms have metastases. 20% are occult, so 20% metastasize through the blood. So when a patient goes in and gets diagnosed with cancer, about 50% of them, it has already metastasized. It's already spread to a secondary location. There's also this phenomenon called seeding. So when cancers of, for example, the colon, the cervix, the uterus, the ovaries, cancers within the abdomen, those cancer cells have the ability to just fall off and fall into the abdominal wall. And then they'll grow in new locations inside the abdomen. A lot of times when they do spread into the abdomen, they can end up on the abdominal wall, the peritoneum, or they can end up in the liver. We will talk more about lymphatic and vascular spread as we click through the next few slides. Lymphatic spread is talking about transport through the lymphatic system. So lymphatic system, if you remember, takes fluids from the tissues, cleans it in the lymph nodes, and then dumps it back into circulation. And that's what prevents fluid accumulation in our tissues or edema, like swelling due to the fluid accumulation. The lymphatic system does not have its own pump. It requires the movement of skeletal muscles in order to move fluid through the lymphatic system. So if a person stays still for a period of time, then that fluid isn't going to be circulating. People who lead sedentary lives have an increased risk of developing cancer. Why? Because the lymphatic system can't function when you sit down all day long. So you need skeletal muscle movement in order to move that fluid through the lymphatic system, get the cells to your lymph nodes, allow those lymph nodes to destroy those abnormal cells and dump them back into circulation. Once they're in circulation, then they can be filtered and cleaned out in the spleen, and we can keep a normal, functioning, happy, healthy, moving body. So walking is one of the best exercises that you can do, and it's so simple. But keeping that lymphatic system moving is essential. Vascular spread, we're talking about the blood vessels actually transporting the cells to distant locations. So lymphatic spread is more typical of carcinomas rather than sarcomas. So carcinomas are more spread through the lymphatic system. Sarcomas are more spread through the blood. But this is a vast generalization. It is the rationale for lymph node dissection in many carcinomas. So when you get a carcinoma, you don't just get the tumor removed, you're also going to look into nearby lymph nodes to see if there's any cancer cells in those lymph nodes. The pattern of nodal spread reflects normal lymph drainage. So lung cancer, bronchial nodes, and tracheal nodes are going to be impacted. In breast cancer, the axillary nodes. So axillary, your axilla, that's your armpits. So when you have breast cancer, the axillary nodes are typically impacted. Hematogenous spread, that's talking about spreading through the blood vessels. Sarcomas predominate, but carcinomas can too. The arteries are rarely invaded. It's typically the veins that are the route of hematogenous spread. Thus, the liver and lungs are usually the endpoints of hematogenous spread. Partial flow to the liver and caval flow to the lungs. Renal cell cancer has a propensity to invade the renal vein. So here you can see the tumor, and the tumor itself is going to produce chemotactic factors. Chemotactic factors call cells to it. They attract cells to grow toward the tumor. Tumor angiogenic factors are factors that are going to cause angiogenesis, or the creation of blood vessels. So the blood vessels are going to be encouraged to grow and expand, and the chemotactic factors are going to call it right toward the tumor. There's also enzymes that the tumor is going to release that allows those blood vessels to open up a bit and accept the cells from the tumor into them. So case study that we're going to consider as we go through the rest of this, during a routine gynecological exam, a 69-year-old woman is found to have a pea-sized mass on her right ovary. A biopsy is performed, which confirms neoplasia within the mass. She is quickly scheduled for surgery to remove the impacted ovary, and additional pelvic biopsies are performed to check for metastasis. CA-125 is ordered. So cancer remains the second leading cause of mortality in developed countries, accounting for 23% of deaths in the United States. So you can go ahead and pause the video and review these different charts. I will not ask you specific questions about these charts on the exam, but it's interesting to take a look at. One definition I do want to mention down here, oncogenes. Oncogenes are cancer-causing genes. BRCA1 is the gene that is linked to causing breast cancer and certain types of reproductive cancers. P53, cyclins, those are all examples of factors that can increase your likelihood of developing cancer. So cancer cells are different than normal cells. So the difference between normal and malignant cells is mostly quantitative. Cancer cells are less differentiated and more adapted to survive under unfavorable conditions. They require less oxygen to survive. They contain fewer mitochondria, less rough endoplasmic reticulum, and fewer specialized enzymes. The metabolism of tumor cells is simpler than that of a normal cell. Again, they require less oxygen, contain fewer mitochondria, do not contain all the enzymes found in normal cells, and they don't synthesize all the proteins that are produced by normal cells. Some tumor cells may acquire embryonic or fetal features because they're not differentiated, because they haven't matured up into adult cells, they're kind of still baby cells. Some of them then develop those embryonic or fetal features. So fetal protein, for example, liver cancer cells produce alpha fetoprotein, AFP, which is a product of fetal hepatocytes. Embryonic glycoproteins, for example, carcinoembryonic antigen, or CEA, is produced by cells of the large intestinal adenocarcinoma and normal fetal intestines. So that leads into the discussion of tumor markers. So we learned a little bit about what cancer is, where it comes from, and how it spreads to other parts of the body. But how do we pick it up? How do we tell that we have cancer in the body? Well, in addition to doing imaging studies and biopsies and looking at tissues under the microscope, we can run some blood work. And that's what we do in clinical chemistry. We look at blood work to try to identify different things that are abnormal in the body. So a tumor marker is a biomarker found in the blood or tissue when elevated is linked to cancer. Tumor markers encompass an array of diverse molecules, such as oncofetal antigens, hormones, metabolites, receptors, and enzymes. An oncofetal antigen is a protein produced during fetal development and elevated in individuals with cancer. Tumor-associated antigens are those expressed initially in the embryo, but then they aren't produced at all in the adult. But they can show up again in the tumor, and they're called oncodevelopmental antigens. Examples of those are the carcinoembryonic antigen, CEA, alpha-fetoprotein in testicular cancers, and CA125 in ovarian cancer. So carcinoembryonic antigen is a marker for adenocarcinoma of the colon and also other sites. Alpha-fetoprotein is a marker for hepatocellular carcinoma. Hepat is referring to the liver. So hepatocellular is liver cell carcinoma, cancer of the liver cells, and contain germ cell tumors that contain yolk sac components. So the next few tables that I'm going to go through, you should take detailed notes on. Any number of exam questions could come directly from these tables. You need to know every detail here. So what the tumor marker is, what type it's a marker for, and what its clinical utility is, in addition to whether it's an immunoassay, which is labeled IA, or an enzyme assay, which is labeled EA. So, prostate-specific antigen, PSA, is indicative of prostate cancer. So, the worse the cancer, the higher the PSA levels. It is used for prostate cancer screening, therapy monitoring, and recurrence. So, evaluating whether the cancer has come back. Lactate dehydrogenase, hematologic malignancies, prognostic indicator, so it indicates whether the patient has a good prognosis or not. It's elevated nonspecifically in numerous cancers. Alkaline phosphatase, metastatic carcinoma of bone, hepatocellular carcinoma, so again, liver cell cancer, osteosarcoma, osteo is referring to bone, lymphoma, and leukemia. So lymphoma is referring to the lymph nodes or lymphatic system tissue. Leukemia is referring to the cancer of white blood cells. So determination of liver and bone involvement, nonspecific elevation in many bone-related and liver cancers. Neuron-specific enolase, neuroendocrine tumors, and it's a prognostic indicator and monitoring disease progression for neuroendocrine tumors. Serum M protein, plasma cell dyscrasis, and now you can see IFE is in here and SPE, so we have immunofixation electrophoresis and serum protein electrophoresis. This is used for the diagnosis and therapeutic monitoring of plasma cell malignancies. Plasma cells are differentiated B cells, so they're immune cells that are going to pump out large quantities of antibodies to help fight infection, help mediate allergic reactions, and so forth. So when we have an excess of plasma cells and plasma cells become cancerous, that can be monitored by serum M protein. Serum-free light chains, plasma cell dyscrasis, diagnosis, therapeutic monitoring of plasma cell malignancies, beta-2 microglobulin, hematologic malignancies. It's a prognostic marker for lymphoproliferative disorders. And then you can pause and take a look at this extensive table of endocrine tumor markers. And the endocrine system contains a bunch of organs that are going to release hormones that impact the function of the body. So we have the pituitary gland, the adrenal glands, there's a thyroid, parathyroid, a lot of different tissues can act as endocrine glands all by themselves. The kidneys have some endocrine function. The pancreas has some endocrine function. So you can pause the video, take a look at this, and read through this entire table of different types of tumor markers that we can use to either diagnose, screen, or check the prognosis of particular tumors. And the table continues on this page, so you can again pause the video and take a look at these. So use of oncofetal antigens for testicular cancer classification. So non-seminomatous tumors, if you have a yolk sac tumor, AFP is increased, HCG is normal. A choriocarcinoma, AFP is normal, HCG is increased. Embryonal carcinoma, both are increased. Teratoma, both are normal. A seminoma, the AFP is normal and HCG is increased. So those two, HCG and AFP, can be evaluated through clinical chemistry methods. And then carbohydrates and cancer antigen tumor markers. So CA19-9 is indicative of gastrointestinal cancer and adenocarcinoma. It's used to monitor the response to therapy. CA15-3 is indicative of metastatic breast cancer, and it's used to monitor the response to therapy and to detect recurrence. Same as CA27-29. CA-125 is indicative of ovarian cancer, and it's used to monitor the response to therapy. So why don't we use this to diagnose? Well, in some cases, all of these can be found in the blood in particular levels, and there's no set standard or range that's appropriate or not appropriate. So every patient has a different level that's appropriate for them. So if we know that patient A has a level of 3. Patient B may also have a level of 3 and not have cancer at all. But if we then measure patient 1 a second time, and it used to be a level of 3 and now it's a level of 9, and we measure them a month later and it's a level of 12, then now we can see a trend within that patient of what's going on. Now, if the levels are decreasing, then the tumor may be responding to the treatment. So that's how we can monitor the response to therapy within the particular patient, but still not be able to use it as a diagnostic marker, because the level in each patient is going to be slightly different and physiologically unique to that patient. Receptor tumor markers. So the estrogen receptor in breast cancer, that's a hormonal therapy indicator. So if it's present, then hormonal therapy may or may not be a good idea. Progesterone receptor, again, another receptor for breast cancer. HER2/neu, breast, ovarian, and GI cancer. It's prognostic and hormonal therapy indicator. Epidermal growth factor receptor, head, neck, ovarian, and cervical cancers, prognostic indicator. So the ideal tumor marker would be tumor specific absent in healthy individuals, and readily detectable in body fluids. The ideal tumor marker does not really exist. So PSA is a pretty good one. Prostate-specific antigen. It's specific to the prostate. The problem is that it's not absent in healthy individuals. Even in healthy individuals, it can be slightly elevated. It is readily detected in body fluids, but we can use it for diagnosis and monitoring of prostate cancer. Tumor markers are used for screening, diagnosis, prognosis, monitoring treatment, and detection of recurrence. And this is a table that you can pause and read through because this is a good overview list of all of the tumor markers that you're responsible for knowing in this class. But it also gives you this additional information of what it's used for. So for screening, biopsy indication. Diagnosis, high levels are indicative of disease. Prognosis, high levels are associated with poor prognosis, and receptor status is used for indication of chemotherapy. Monitoring treatment, monitor efficacy of chemotherapy, residual disease after surgery, and detection of recurrence, increase associated with a relapse. So if all of a sudden these levels go up after treatment, then that indicates that the cancer is back. So screening asymptomatic populations would result in false positive test results, patients without the disease with a detectable tumor marker, and risk to patients, so unnecessary imaging, biopsy, and surgery. Prognosis. The tumor marker concentration generally increases with tumor progression. Tumor marker levels at diagnosis help predict the outcome for patients. Monitoring effectiveness of therapy and disease recurrence. So after surgery, radiation, or chemotherapy, tumor markers are followed serially. So there is a particular schedule that blood will be drawn to follow the effectiveness of the treatment. Effective therapy results in a dramatic decrease in the tumor marker level. If the initial treatment is effective, the appearance of circulating tumor markers can be used as a highly sensitive marker of recurrence. So there are two main laboratory considerations. A lack of standardization makes comparison of serial patient results difficult. There are multiple reasons why these assays are not comparable, including differences in antibody specificity, analyte heterogeneity, assay design, lack of standard reference material, variation in reference ranges. To more accurately monitor tumor marker concentrations in a patient, it is important to use the same methodology. And using the exact same method is tricky. So the best way to do it would be having the same tech do the same test with the same kit and the same lot number each time. And if you know how the clinical lab works, that's nearly impossible to do. People work all different shifts. There's all different time frames. Lot kits are used up and there's new kits that come in. The machine is constantly being QC'd and maintained, and things happen in between. So it's tough to get accurate serial patient results. The wide range of tumor marker concentrations is encountered clinically. So that goes back to my point of levels may be different based on that individual patient. Immunoassays are commonly used method to measure tumor markers. Linearity, the linear range is the span of the analyte concentrations over which a linear relationship exists between the analyte and signal. Samples exceeding the linear range need to be diluted to determine the result. Excessively high tumor marker levels can result in falsely low measurements, a phenomenon known as antigen excess or the hook effect. So if there's too much of it there, sometimes the antibody can't interact with that much. There isn't a good antibody to antigen ratio. So you get falsely decreased levels. And this is the hook effect. So up to a certain point, it's a good good diagnosis. And then all of a sudden you have this drop off because you have too much of the tumor marker and the antibody to tumor marker ratio isn't great. HPLC is commonly used to detect small molecules such as endocrine metabolites. Immunohistochemistry and immunofluorescence are used to detect solid tissue tumor markers. An example of the use of a tumor marker that is detected by immunohistochemistry is the identification of estrogen and progesterone receptors in breast cancer. Enzyme assays. Examples of enzymes that have been used as tumor markers include alkaline phosphatase, lactate dehydrogenase, and PSA. So now we're going to go through several very important tumor markers in the tests and clinical application. So you can review these, pause the videos, look through them. I'm just going to briefly go over these, and then you should definitely take detailed notes on these for the exam. So alpha-fetoprotein, AFP, functions as a transport protein. AFP is used for the diagnosis, staging, prognosis, and monitoring of hepatocellular carcinoma, so liver cancer. AFP is measured using a variety of automated immunoassays, and the primary applications are for hepatocellular carcinoma and testicular cancer. CA125, cancer antigen 125, is expressed in the ovary and in human ovarian carcinoma cells. It is a serological marker of ovarian cancer. It can be detected by immunoassays, and it's used to monitor therapy and distinguish benign masses from ovarian cancer. Carcinoembryonic antigen, CEA. It's involved in apoptosis, or programmed cell death, immunity, and cell adhesion. The main clinical use is a marker for colorectal cancer. CEA can be detected by immunoenzymatic sandwich assays. Before surgical resection of the colon, a baseline CEA values are obtained. Then after surgery, CEA levels are monitored for every 2 to 3 months to detect recurrence. Human chorionic gonadotropin, HCG. HCG consists of an alpha and beta subunit. This is the pregnancy hormone, so when the sperm penetrates into the egg, it's going to divide into this mass, and this mass is eventually going to implant. And once that mass implants, it's going to start producing HCG, and that is detected by a pregnancy test. So immediately upon fertilization, HCG can start to be produced in low concentrations. However, it's not enough to be detected by a pregnancy test until typically after implantation occurs. So once it's detected, its main function, other than telling someone that they're pregnant, is to tell the corpus luteum to stay intact and to build up the corpus luteum and get that corpus luteum to produce progesterone. Progesterone is going to maintain the uterine lining throughout the pregnancy. So as long as we have HCG present, progesterone is going to be produced, and progesterone is going to maintain that uterine lining so that the baby can develop in the uterus. It is a prognostic indicator for ovarian cancer, a diagnostic marker for the classification of testicular cancer, and it's used in the detection of gestational trophoblastic diseases. HCG can be measured using automated immunoassays. Testicular cancer, ovarian cancer, and gestational trophoblastic diseases can be detected. PSA, there's 2 forms, free and bound. PSA reference range is age dependent, so less than 4 is considered normal. If PSA is 4 to 10, then a free PSA should be performed. It's measured by immunoassay, and it's used to monitor for the progression of prostate cancer after therapy. Mucin 1 is responsible for encoding CA15-3. It's useful for managing breast cancer patients. It can be detected by immunoenzymatic sandwich assays, and its serial testing is to assist in early detection of breast cancer recurrence. CA19-9 is a modified Lewis blood group antigen. It's useful in diagnosis and monitoring of pancreatic cancer. It can be detected by immunoenzymatic sandwich assays, the best validated biomarker for pancreatic cancer. Immunoglobulin-free light chains. Some monoclonal light chain diseases cannot be detected by SPE or IFE, serum protein electrophoresis, or immunofixation electrophoresis. It is useful for monitoring patients with monoclonal light chain disease without an M spike identified on serum protein electrophoresis or immunofixation. Methodology: serum kappa or gamma free light chains FLC can be measured using nephelometry. The FLC assay minimizes the need to perform urine protein electrophoresis. Human epididymis protein 4, HE4, has been shown to be overexpressed in ovarian carcinomas. HE4 measurement is a part of the risk of ovarian malignancy algorithm. HE4 can be detected by immunoenzymatic sandwich assays. HE4 is primarily used for ovarian cancer. Neuron-specific enolase. Enolase has three enzymes, alpha, beta, gamma. NSE gamma is found in the neuroendocrine tissues. Clinical usefulness and interpretation. NSE is useful as a follow-up marker in patients with NSE-secreting tumors. NSE is an auxiliary test in the diagnosis of small cell lung carcinoma. NSE may be measured by a homogeneous immunofluorescence sandwich assay. NSE is elevated in patients with small cell lung carcinoma, carcinoid tumors, islet cell tumors, and neuroblastomas.